I'll kind of briefly introduce the TIVO-3 study, and then we'll quickly get to what the more recent longer-term data follow-up showed. So just as a reminder, TIVO-3 was a randomized phase 3 trial for patients with metastatic RCC who'd progressed on prior therapy. About 2/3 of patients had had 2 prior lines of treatment, and the remaining had had 3 prior lines of treatment, just to contextualize that this is a pretty refractory patient population. And so Tivozanib was compared, a novel TKI at that time was compared to sorafenib, and the primary endpoint was PFS, and it met that primary endpoint, PFS of 5.6 months compared to 3.9 months with sorafenib. And so that got it 2021 FDA approval, and certainly I've been using it in the clinic since that time. And I think what this paper that we're both co-authors on, to put full disclosure out there, attempted to do was to understand in the longer term setting, were patients able in the refractory setting to have long-term benefit. So maybe, starting there, Dr. Hutson, I wonder, did this long-term data, if you wanted to, summarize some of that and say how that helped support what you do in clinic, or how you think of it in the treatment landscape.
Yeah, so I mean, I think what's most important about this study is that it included a population that we would consider a modern population. So they were exposed to what we would consider was best practice or standard of care today. And that's been some of the limits in some of the previous studies of other agents that one could consider using, as you end up extrapolating to a population that is dated. And so it was great to see this drug have a degree of activity that we could point to and feel really comfortable in clinic of taking off the shelf and using the patients, knowing that we had this data set to support that up. So what was nice about the data was that you clearly see a separation of the curves and some of the efficacy endpoints when it comes to PFS. And that's great. We saw overall survival hazard ratios, which are positive for a benefit. And most importantly, as you mentioned, and what was important with this manuscript is kind of looking long term. Is this patient population that's benefiting? First off, are they harmed long term? Well, they obviously are not. Do they continue to benefit? Yes. And if you track the PFS curves out there, there's that maintained separation. Understanding that patients some of them are getting post-progression therapy. So they're getting therapies and they're able to access therapies. And even doing so, the survival curves are how they are, suggesting that there's this maintained benefit. So having the exposure to Tivozanib ultimately provided a benefit to these patients long-term for the rest of their life. And that's one aspect of it. And a lot of times, what we see when we move into patients into the 3rd, 4th, 5th line, 6th line, a lot of the goal of the therapy is a lot different for the patient. I think it's unrealistic oftentimes to think of significant tumor shrinkage, although that happens rarely and we celebrate it with the patients. Ideally, it's disease control and even allowing slow amounts of a little bit of growth. In clinical trials, you can still be stable disease and have up to 20% tumor growth. So, we factoring some oozing of the tumor there, but allowing patients to have a side effect profile that's predictable and tolerable to allow them to really get to end of life goals. And I think that's such a focus as we get into later line therapy. So this was a very refreshing data set of showing us that there is this maintained benefit. And I'm actually sitting here on my computer screen just paging through, the data as it stacks up against sorafenib, and you just see even at 48-month progression-free survival and looking at the, how that pans out, you just see this continued benefit, stay out with longer term follow-up. Right. So I think that's important, and that's important as we start looking at some newer agents. I don't want to lead the next question in there, but obviously I'll let you ask the next questions. But we do have some newer therapies coming that are going to juggle the space in the refractory setting. So this data set is the most mature. Obviously, newer drugs don't have this type of data. And so I think in any way, Tivozanib is well positioned to remain as a standard therapy option somewhere, in my opinion, somewhere for its use to be hopefully within the first 4 lines of therapy. And that takes the bulk of therapy. And some of the newer agents, sometimes they may come out in the refractory setting, but really ultimately they're going to be an agent that ends up being combined potentially earlier in So you still may end up having 4 lines of therapy, although we may have 5 agents now. But I'll throw it back at you, Katie.
Yeah, no, and I like that. And maybe just to kind of highlight one other thing that you mentioned, and as we transition maybe to talking about where this does end up landing in the different treatment options, I think, also what this data showed, now having longer follow-up, to your point, that this is a refractory patient population. The goals, are, we hope, as long of a durable benefit that's tolerated, and so while not necessarily quality of life here, we certainly saw, patients able to be on treatment for 11 months compared to sorafenib, closer to like the 4 or 5 month range, and that the grade 3 adverse events, treatment related, were less so in tivozanib than in a sorafenib patient population. And so I think all those things need to be highlighted, because these patients who have been through multiple prior treatment options have often been through other side effects, maybe having symptoms from their cancer and other things that are detracting from their quality of life. So I think it's also just nice to see that, and there was a subgroup analysis, again, all post hoc, but looking at even the most elderly of patients, those greater than 75 didn't require an increased discontinuation or dose reduction, again suggesting can be tolerated.
And the conclusions, are really, so especially if you look in the group of responding patients and you follow them out for over 4 years, and there's still that clinically meaningful benefit that they have. And I think the conclusion statements of the article that you're first author of are absolutely true, that this benefit was seen across all age groups, regardless of prior therapies, and regardless of age, prior immunotherapy exposure, and all that. Those things are important things to consider. And we have this subgroup of patients that really do well long-term after exposure with this drug.